When you break a bone, the X-ray just shows this jagged white line.
Right, it's unmistakable.
Yeah, exactly. The doctor just points to it and says, there it is. It's totally binary, broken or not broken.
If only everything in medicine were that simple.
Right. But today we're basically throwing out the X-ray machine. We've got a stack of clinical management guidelines in front of us, and we are looking at 3 notoriously complex connective tissue and systemic disorders.
We're looking at lupus, gout, and fibromyalgia.
Yeah. And our mission for you today for this deep dive is to decode how these chronic, honestly, often incurable conditions hijack the human body in just completely different ways, and, how modern medicine actually attempts to manage them.
Because, we really have to emphasize, these aren't just simple joint aches.
Oh, not at all. We are dealing with bodies literally attacking their own DNA. We're talking about microscopic crystals forming in your toes and pain that literally changes with the weather. Okay, let's unpack this.
Yeah, and I think we should start by acknowledging that while these 3 disorders seem entirely distinct on the surface, one is autoimmune, one is metabolic, and one is neurological, they actually share this fascinating web of systemic inflammation.
Like, they overlap more than people realize.
Exactly. There's a surprising amount of overlap in the patient experiences. It is, it's the absolute definition of diagnostic muddy waters.
Muddy waters. Yeah, that is the perfect phrase for it. Let's start with the most complex of the 3 then. The ultimate autoimmune chameleon lupus erythematosus.
It's a beast of a condition.
It really is. Like, imagine your body is a high-tech smart home, right?
Yeah.
Usually your internal security system, your immune system, keeps the bad guys out.
Right, spots the virus and locks it out.
Exactly. But with an autoimmune disorder like lupus, small antigens basically bond with healthy tissue, and your security system just goes completely rogue. It starts locking the doors and produces antibodies that actively attack the homeowners.
Yeah.
It attacks your own healthy tissue.
It's a terrifying malfunction. And what triggers that security system to go rogue can be, a myriad of things.
Like what? What sets it off?
What could be environmental toxins, bacteria, viruses, or even, and this surprises a lot of people, just UV light exposure from the sun.
Wow, just sunlight.
Yeah. And the key thing to understand here, right off the bat, is that there is no cure. The entire goal of medical management is just to control the manifestations and decrease the frequency of those sudden, severe flare-ups, exacerbations.
Right. And I noticed in the sources that lupus isn't just one monolithic disease. They break it down into a few distinct types.
They do, yeah.
There is systemic lupus erythematosus, or SLE, which that seems to be the really dangerous one because it affects multiple organ systems.
Yes, SLE is the most severe.
Then there's discoid or cutaneous lupus, which I think only affects the skin, right?
Right, it causes these coin-shaped lesions.
Okay, got it. And then there's a third type mentioned that kind of blew my mind, medication-induced lupus.
Ooh.
Like, how does a medication trick your body into an autoimmune disease?
Well, it's entirely triggered by specific prescription drugs. Things like procainamide for heart arrhythmias, hydralazine for blood pressure, or even isoniazid, which is used for tuberculosis.
Okay, so common drugs.
It's very common. And the chemical structures of these drugs can sometimes bind to proteins in the patient's cells. And it alters them just enough that the immune system no longer recognizes them as self.
It thinks the cells are invaders.
Exactly. It flags them as foreign. But the remarkable thing about medication-induced lupus is that the findings actually resolve once the medication is discontinued.
Oh, really?
Yeah, just a temporary malfunction of that security system. Once the drug is gone, the immune system resets.
So if you stop the drug, the body stops attacking itself. That's a relief. But for SLE, the systemic kind, who is most at risk? Because the demographic data points heavily to women.
Very heavily, yes.
Specifically between the ages of 20 and 40. And it disproportionately affects specific ethnicities, like African American, Asian, Hispanic, and indigenous populations. Why is it so incredibly specific?
It really comes down to a complex mix of genetics and hormones. Estrogen is thought to play a really significant role in immune system regulation.
Oh, which explains why women of childbearing age are the ones predominantly affected.
Exactly. And the higher prevalence in certain ethnic groups points to specific genetic markers. When those markers combine with environmental triggers, the immune system is just far more likely to misfire.
That makes a lot of sense. But here's my question about actually diagnosing this. The clinical guidelines list physical findings like extreme fatigue, joint pain, maybe some weight
Like
loss.
symptoms soon.
Very vague symptoms, yeah.
Right. So if a patient is older, say they're in their 60s or 70s, how do doctors even catch this early on? Doesn't all of that just mimic normal aging or, common comorbidities like osteoarthritis? It does. And that is a massive clinical hurdle. Diagnosis in older adult is frequently delayed precisely because those symptoms are so generalized.
So what do they look for then?
Clinicians have to look for the specific hallmarks. The most famous is the erythematous butterfly rash.
Oh, I've heard of that.
Yeah, it's a raised, dry, scaly rash that spreads right across the bridge of the nose and the cheeks. But they also look for alopecia hair loss and chest pain when breathing, which is called pleuritic pain, and Raynaud's phenomenon.
Raynaud's, wait, that's when the arterial spasm in response to cold or stress.
Yeah.
Right. Causing the hands and feet to turn pale, then blue, then red.
Exactly. The blood vessels are essentially overreacting to temperature changes. But, where the diagnosis of lupus really gets locked in is the lab work. This is how we prove that the security system has actually gone rogue.
Because they run that immunologic test, right? For anti-nuclear antibodies or ANA titers.
Yes, the ANA test.
The source says these are positive in 95% of clients who have lupus. And these antibodies are literally produced against the patient's own DNA.
It's incredible, isn't it?
It is staggering to think about. Your body is creating weapons targeted at your own genetic blueprint. How does a lab test even see an antibody attacking DNA?
It's actually a brilliant piece of diagnostic medicine. In a lab, they take a sample of the patient's blood serum, which contains the antibodies, and they introduce it to cells with very large visible nuclei.
Okay.
Then they add a fluorescent tag. If the patient's antibodies are targeting DNA, they will bind directly to the nuclei of those test cells. And under a microscope, the nuclei will literally glow fluorescent green.
Wow. So you can physically see the friendly fire happening on a cellular level.
You can. And what's fascinating here is the role of the serum complement proteins, specifically C3 and C4.
I saw those in the notes. What do they do?
Well, our immune system relies on a complement system made up of 9 major proteins to develop inflammation and fight off threats. But in systemic lupus, the immune response is so incredibly exaggerated, it's so hyperactive, that the body literally depletes its own stores of C3 and C4.
Wait, so instead of seeing elevated immune markers, which you'd expect with inflammation, the labs actually show a decrease in C3 and C4.
Correct. The security system is working so frantically that it burns through its own battery supply.
That is wild.
You'll also see something called pancytopenia on a complete blood count. That is a deficiency in all 3 cellular components of the blood.
Red cells, white cells, and platelets.
Yes. The body is just in a state of systemic warfare, destroying its own blood cells faster than the bone marrow can replace them.
So, building on that faulty security system analogy, how do we shut off those alarms without leaving the house completely defenseless? Let's look at the management of lupus, because it is a massive undertaking.
It's a lifelong commitment.
Yeah, the medications alone are intense. You have NSAIDs to reduce inflammation, corticosteroids like prednisone to suppress the immune system, and then it escalates to heavy-duty immunosuppressants.
It's a heavy regimen. For severe cases, clinicians use drugs like methotrexate or newer biologics like belimumab.
I saw belimumab on the list. What is a biologic actually doing in this context?
Belimumab is a human monoclonal antibody. It's essentially a lab-made protein designed to bind to one specific target. In this case, it targets and inhibits a protein that normally stimulates B cells.
Okay, and B cells are the ones making the antibodies.
Exactly. Since B cells are the factories that produce those rogue antibodies attacking the patient's DNA, belimumab effectively shuts down the factory.
Okay, that makes sense. And then there are antimalarial drugs. The guidelines mention hydroxychloroquine. Why are we giving malaria drugs for an autoimmune disease?
Right, it sounds strange. But it turns out hydroxychloroquine has powerful anti-inflammatory properties that go far beyond malaria. In lupus patients, it suppresses synovitis.
Synovitis, is that just inflammation of the joint lining?
Exactly, the synovial membrane that lines your joints. So it helps with the joint pain, the fever, and the fatigue. But more importantly, it decreases the risk of developing those skin lesions from the absorption of UV light. It's a fantastic tool, though it does require the patient to have very frequent eye exams because it can accumulate in the retina and affect vision.
That's a serious side effect. And, the lifestyle changes required are just as rigorous. Patients are educated to wear wide-brim hats, long sleeves, basically avoid the sun entirely. They have to use mild protein shampoos, pat their skin dry instead of rubbing it. And they have to avoid live vaccines for 30 days before starting immunosuppressants.
Right, the precautions are extensive.
I have to push back here for a second, though. We're giving these patients drugs that require them to avoid crowds, avoid sick people, and skip live vaccines. Doesn't this treatment feel almost as risky and life-altering as the disease itself?
It is. It is a reality every lupus patient grapples with.
Hmm.
But to understand why the treatment is so aggressive, we have to look at the consequences of not suppressing that immune system.
Which are what?
The complication clinicians fear most is lupus nephritis.
Oh.
If the inflammation isn't controlled, the antibodies attack the filtering units of the kidneys. The blood urea nitrogen, or BUN, and creatinine levels spike, protein and red blood cells spill into the urine, and it rapidly leads to chronic kidney disease.
Oh, wow.
Lupus nephritis is actually the leading cause of death related to SLE.
Hmm.
Another major complication is pericarditis, where the sac surrounding the heart becomes inflamed.
So you are basically trying to suppress the immune system just enough to prevent major lethal organ failure, but not so much that a common cold becomes life-threatening.
It is the ultimate clinical tightrope walk. It requires constant monitoring and lifelong adjustments.
Okay, that is the systemic DNA-level misfire of an autoimmune disorder. Let's switch gears and look at a completely different kind of connective tissue pain.
Let's do it.
Not a rogue security system, but a localized metabolic traffic jam. Let's talk about gout.
Gout is fascinating because it contrasts so sharply with lupus. It is the most common inflammatory arthritis, affecting over 3% of the population. But instead of antibodies attacking tissue, gout is caused by a disruption in purine metabolism.
Right, which leads to hyperuricemia, meaning serum uric acid levels are elevated above 6.5 milligrams per deciliter.
Correct.
The way I picture this is it's like making a glass of iced tea. If you keep dumping sugar into the tea, eventually it can't dissolve anymore, right?
Yeah.
And the sugar supersaturates and crystallizes at the bottom of the glass.
That's a great way to visualize it.
Except in this scenario, the glass is your joint, usually your big toe, and the sugar is literally uric acid crystals.
That iced tea analogy perfectly captures the chemistry of what's happening. And the body reaches that state of supersaturation in two ways: primary and secondary gout.
What's the difference?
Well, primary gout is the most common. It usually has a genetic component affecting middle to older adult males and postmenopausal individuals. It happens when the body's production of uric acid simply outpaces the kidney's ability to filter it out.
And secondary gout is when another condition entirely like chronic kidney failure, certain cancers, or excessive diuretic use causes that uric acid to spike in the blood.
Exactly. It's secondary to another disease process.
But let's look at the risk factors for gout in general, because this is wild. The sources list heredity, a body mass index over 30, trauma, excessive alcohol ingestion, and starvation dieting.
Yes, that always catches people off guard.
Here's where it gets really interesting. Why would eating less, going on a starvation diet, cause a condition that we historically associate with excess, like the disease of kings?
Let's use your iced tea analogy again. Uric acid is a byproduct of purine metabolism.
Mm-hmm.
When you go on a starvation diet, your body enters a state of rapid cell breakdown to find energy.
Right.
That massive cellular breakdown releases huge amounts of purines into your bloodstream. You basically just dumped a massive scoop of sugar into the glass.
No, I see.
But at the same time, starvation changes the pH of your blood, making it more acidic. That acidity impairs the kidney's ability to excrete the uric acid. So not only did you dump in more sugar, but your spoon completely stopped stirring.
Wow. So the supersaturation happens incredibly fast.
Yes, and those microscopic crystals precipitate directly into the joints.
The kidneys just get completely overwhelmed, and when those crystals deposit, the symptoms are brutal. Severe joint pain that spontaneously subsides in 3 to 10 days. And it loves the metatarsophalangeal joint, the big toe.
It's excruciating.
Yeah, it gets red, swollen, warm, and is like agonizing just to touch. And if it becomes chronic, you get these things called tophi. The guidelines describe them as literal deposits of sodium urate crystals sitting right under the skin.
Yeah, you can visibly see them in severe cases. And because it's a metabolic issue, the medical management is highly targeted. For acute attacks, the goal is to stop the inflammatory cascade. They use NSAIDs, like indomethacin, or a very specific anti-gout agent called colchicine.
How does colchicine work? Does it dissolve the crystals?
It actually doesn't touch the uric acid levels at all.
Wait, really?
Yeah. The severe pain of a gout attack isn't just from the physical crystals. It's because your white blood cells migrate to the joint and try to swallow the crystals, which triggers a massive release of inflammatory chemicals.
Oh, so the immune response is causing the pain.
Exactly. Colchicine essentially paralyzes the white blood cells, stopping them from migrating to the joint and throwing fuel on the fire.
That is incredibly specific. But for chronic maintenance care, you actually do want to dissolve the crystals and lower the uric acid.
Right. For maintenance, clinicians use drugs like allopurinol to decrease uric acid production, or probenecid, which promotes its excretion through the kidneys. Interestingly, the guidelines explicitly note, if a patient is on probenecid, they absolutely cannot take aspirin,
Why not?
because aspirin actually blocks the kidney channels that probenecid is trying to open, rendering the drug completely ineffective.
Oh, wow. That's a crucial interaction to know. There is also a treatment mentioned for refractory gout-meaning patients who just don't respond to any of those standard maintenance medications.
Right.
It's an enzyme treatment called pegloticase.
Administered intravenously every other week, yes.
Right. How does that one work?
Pegloticase is fascinating. Humans actually lack the enzyme to break down uric acid, which is why it builds up. Pegloticase is a synthetic version of an enzyme found in other mammals.
So we borrow it from other animals?
Essentially, yes. It literally converts the uric acid into allantoin, which is a harmless, highly water-soluble substance that the kidneys can easily flush away.
That sounds like a miracle drug.
It is, but because it's a foreign protein introduced into the body, there is a very high risk of the patient's immune system attacking it, leading to anaphylaxis. It requires intense clinical monitoring.
And of course, the dietary changes are crucial too. A strict low purine diet. That means absolutely no organ meats, no shellfish, limiting alcohol, and drinking massive amounts of fluids to keep the kidneys flushed and the tea diluted.
Exactly.
Okay, so we've seen physical crystals in gout, and we've measured DNA-attacking antibodies in lupus. But what happens when a patient is in severe, debilitating pain, but the physical tissue and the lab work look perfectly fine?
That's where things get really complicated.
Right, enter the invisible web, fibromyalgia.
Fibromyalgia is a chronic pain syndrome that affects roughly 5 million people in the United States alone. And it is incredibly challenging to diagnose precisely because it doesn't leave those obvious physical calling cards, like a swollen toe or a glowing anti-nuclear antibody.
It manifests as a burning, gnawing pain that is elicited by palpating very specific trigger points on the body. But the source material highlights a crucial fact. An estimated 25% to 65% of people who have fibromyalgia also have another rheumatologic disorder, like SLE or rheumatoid arthritis.
And that overlap is a critical piece of the puzzle. It shows us that these systems do not exist in isolation. With fibromyalgia, the symptoms extend far beyond joint pain.
What else do they experience?
Patients experience mild to severe fatigue, numbness and tingling in the extremities, and intense sensitivity to noxious smells, loud noises, and bright lights. They have gastrointestinal manifestations like abdominal pain and genitourinary issues like urgency and pelvic pain.
And their pain and tenderness literally fluctuate based on stress, physical activity, and this blew my mind, weather conditions. How does a cloud moving in cause physical joint pain?
It relates to barometric pressure. When a storm rolls in, the barometric pressure in the atmosphere drops.
Okay.
That drop in external pressure allows the tissues in our bodies to expand ever so slightly. For most of us, we don't feel it. But for a fibromyalgia patient whose nerve endings are profoundly hypersensitive, that microscopic tissue expansion presses on the nerves and registers as severe burning pain.
Wow. That leads perfectly into my analogy for fibromyalgia. It basically feels like the brain's internal volume knob for processing physical sensations is broken, and it's permanently stuck on maximum.
That's a great way to put it.
A normal sensation, like a slight drop in air pressure, feels like a blaring siren to their nervous system.
Central sensitization is the leading theory behind fibromyalgia, and your volume knob analogy hits it exactly. The central nervous system is malfunctioning, amplifying pain signals completely out of proportion to the actual physical stimuli.
I want to ask about the medications, though, because the list completely puzzled me when I read the source. If this is a physical pain syndrome, why are the primary treatments things like SNRIs, like duloxetine? Just to clarify for you listening, SNRI stands for serotonin norepinephrine reuptake inhibitor, which is an antidepressant.
Right.
They also list anticonvulsants like pregabalin and tricyclic antidepressants like amitriptyline. Why are we treating physical joint pain with antidepressants and seizure medications?
If we connect this to the bigger picture, we see that pain, sleep, and neurotransmitters are entirely interwoven. The risk factors for fibromyalgia include trauma, infection, and deep sleep deprivation.
Sleep deprivation.
Yes. Deep sleep deprivation isn't just a symptom here. It is a profound driver of the disease. When you don't get deep restorative sleep, the central nervous system becomes hyperreactive. The volume knob gets turned up.
So how do the SNRIs turn it down?
Well, SNRIs and anticonvulsants work by increasing the levels of serotonin and norepinephrine in the brain and spinal cord.
Okay.
These neurotransmitters don't just regulate mood, they actually act as a descending pain inhibitory pathway. By boosting them, you're essentially closing the biochemical gates in the spinal cord, preventing the pain signals from reaching the brain.
That is fascinating. And what about the tricyclic antidepressants?
We use tricyclics not necessarily to treat depression, but because they forcefully induce restorative sleep.
Oh, they force the body into that deep sleep state to reset the nervous system's threshold.
Exactly. Trazodone, for instance, is often preferred for older adults because it has fewer adverse effects than amitriptyline.
Right, amitriptyline can cause confusion and dangerous drops in blood pressure upon standing. I saw that in the notes.
Yes. The guidelines also mention tramadol, which has both opioid and tricyclic components to reduce pain, though obviously with a heavy caution about dependence. But, medical management is only one pillar.
What else is there?
The sources heavily emphasize cognitive behavioral therapy, acupuncture, tai chi, and establishing strict sleep routines. It's a holistic reprogramming of the body's entire alarm system.
Taking a step back for you, the listener. Look at the journey we just took. We explored the rogue autoimmune attacks of lupus, the localized metabolic crystal supersaturation of gout, and the invisible overamplified neural misfires of fibromyalgia.
It's a lot to process.
It really is.
Right.
But it showcases the incredible, intricate balance of the human body and how highly tailored medical management must be when that balance is lost.
I want to leave you with a final thought to ponder. We noted earlier that up to 65% of fibromyalgia patients also have an overlapping condition like lupus or rheumatoid arthritis. And we saw that they share profound systemic triggers: emotional stress, physical trauma, severe infections. Given all of this, could these seemingly distinct categories, autoimmune, metabolic, and neurological pain, actually be clues to a single, massive, undiscovered web of crosstalk between the immune system and the nervous system? Are we currently treating the branches of a tree when we should be looking at the root?
Wow. So what does this all mean? It means that X-ray machine we talked about at the beginning, it is definitely broken. The human body is not a clean binary engineering diagram. It is a brilliant, messy, deeply interconnected ecosystem. And in these muddy diagnostic waters, there are still so many new dots waiting to be connected. Thanks for joining us on this deep dive. We'll see you next time.